You're listening to Vaccine Curious. The coronavirus pandemic begs the question, what do we know about vaccines? This podcast investigates vaccines from an individual, a societal, and scientific perspective. Your host is Professor in Global Health from University of Southern Denmark, Christine Stabel-Ben. Welcome to Vaccine Curious.
Peter Aaby, Professor in Global Health and Childhood Vaccines at University of Southern Denmark. It's a great pleasure to welcome you here at this podcast, where I've invited you to talk about the discovery of non-specific effects of vaccines. You were the person who introduced me to non-specific effects of vaccines when I came to Guinea-Bissau in 1993. How did you discover that vaccines have non-specific effects?
Thank you for the invitation. As a background, I'm an anthropologist by training, so it hasn't been sort of a straight going into the medical field and making a discovery. The whole thing started in Guinea-Bissau, which is the former Portuguese Guinea, which became independent in 1974. And the country was very poor, and it had a very high mortality. Around 50% of the children died before 5 years of age. So Sweden was the major donor for Guinea-Bissau at that time. So Sweden decided, the agencies in Sweden like SIDA and SAREC, they decided that they would do a study of what was the causes of malnutrition. Everyone at that time knew that the reason that the children died in Africa were malnutrition.
They knew that?
They knew that. It's in all the textbooks. It's all the programs. I have asked 100 times, I've asked audiences, why are children dying in low-income countries when diseases that, like measles, is relatively mild in the Western world? And the answer was invariably malnutrition.
Had they studied that, or was that an assumption?
In some way, but not really. It was so self-evident, and it was strongly sort of reinforced by the campaigns against hunger in Sudan and Eastern Africa in the 80s. So it was in the 70s and 80s. So that was the general feeling that this was the reason. So Sweden clearly started this project to find out why were the children in Guinea-Bissau malnourished, and the ambition was that we should find out what was missing in their food, how could we then train them, train the peasant to cultivate other things. And so the reason to have an anthropologist on this project about malnutrition was to find out what was the food habits and what was the food taboos. And Sweden was ambitious in the sense that they had a multidisciplinary team of two anthropologists and a physician and a nutritionist. And when the work started in 1978, we quite rapidly became very surprised because the children were not malnourished. They had a very good breastfeeding until 2 years of age normally, which means that there were very few severely malnourished children. And when we made our first survey in December 1978, we only found two children who were severely, out of 1,200 children, we only found 2 children who were severely malnourished. And the reason was quite obvious. Sorry. The reason was obvious because their mother had died at delivery. So it was the grandmother trying to take care of them. So you didn't need a multidisciplinary team to decide why they were malnourished. So we were kind of sort of walking around in a very strange situation. We were there to find out why were the children malnourished, but they weren't malnourished. Then what was the whole thing going on here? But we had to do the surveys in the different parts of the country. And while we were sort of main part of the team were in the interior of Guinea-Bissau to examine the malnutrition situation for different ethnic groups in different ecological areas. There was a measles epidemic in the capital, in the area which has been called Bandim, and which has become sort of the main area for the project. And this measles epidemic clearly became, it was much bigger than anyone had thought about, and it was very severe. And we later found out that around 25% of the children who got measles died of the infection. And that again was sort of very strange. If the children were not very, very malnourished, why would 25% of the children die? Because you could at that time you could read in any textbook that the reason for high measles mortality in Africa were malnutrition. And I'm not going to tell that story completely, but we later found out that the real reason was not malnutrition. It was the crowding. They had very big families, and then they had houses with multiple families living in the same house, and on average there were 18 persons per house. So some houses would have had 40 people. So that meant there was a lot of kids. And what we found out was that those who die of measles is not the children who catch the infection from the neighbor or the kindergarten or whatever. It's the children who are infected at home, who are sleeping in the same bed as the first case. So the most logical explanation here is that it's intensity and the dose of infections which determines who dies of infections. So if you put a lot of children together who have not been vaccinated, you can easily get high mortality, and you can get high mortality everywhere.
So the suggestion...
This was an unusually crowded environment. If you had 18 persons per house, so it meant that you had on average 4 to 5 kids under 5 in every house. But this took a long time to find out, and to find out that there are data, historical data, which you can show exactly the same thing. When mortality was high in Europe in the beginning of the 19th century, you can see we have shown that later with data from Blegdomshospitalet, that it was also the kids who were infected at home who died of measles at that time.
So the main reason that measles is now considered a mild disease in our part of the world is that there isn't that much crowding in the homes.
Yeah, it's that, but it's also that you have moved the kids out of the home. Sort of in the old days, 200 years ago, the normal way of infecting would be that the children met in school, and then the disease spread in school. And then they took the older children of around 6 or 7 years, they took the infection back to the family, and then they infected their smaller siblings. And it was those smaller siblings who would then die when mortality was also high. But when we started to have public child care, partly we made cities where a lot more people in the 1800s, there was a huge increase in the urbanization. So you got bigger population, and if you have a bigger population, then the infections occur much earlier, which means that you have only each child. If a family have several children, the children will tend to be infected in different epidemics in different years. Whereas if you go to a rural area, where there may be 10 years between the epidemics, then there will be many children who are susceptible, and therefore you would tend to have higher mortality from measles in the rural areas than you have in the urban areas. And that's not because the children in the urban areas are more wealthy. They usually weren't, because this was the poor families having a lot of kids under some bad crowding conditions. So we eventually, this probably took 10 years, established in many different African countries and in historical data that it was the intensity of exposure. It was the fact that you were infected at home, which was meant that you had a higher risk of dying of the infection. And the nutritional status had no implication for that. It had no importance for that situation. That was very controversial at the time, and eventually the Swedish agency which had employed us, they fired us because they were too surprised by these things, and they didn't. The physicians who were involved in this, they didn't like the results. But that's not really how the non-specific effect. This is the background. You had to have sort of a number of contradictions you had to explain to sort of believe, to be able to see things in a new way. And I think if the physician has just said at that time, this is interesting, I had probably gone back to anthropology and been a professor at the Institute of Anthropology. But instead they fired us and they said, this is impossible. You can't have an anthropologist coming and telling the physician how things should be.
The thing you have told them was that malnutrition wasn't the cause of the high mortality.
Yeah.
And that, in fact, did you also tell them at that time that you thought crowding was the real factor?
Yeah, sure.
Yeah.
Those two things are sort of the same kind. The reason was that they, we said that it was a dose of infection which was probably the cause of high mortality, and we used the data we had. But it was also that the project had not been planned to study measles. It was to study the nutritional situation. So we have some data which was indicative, but we wanted to get back and examine all the kids in the study area where we knew who had died, but we didn't know all the children who had we didn't have the information on all the children who had actually had measles. We had some, but we didn't have all the data. So I wanted to get back and actually interview all the mothers about whether their children had measles or not, and particularly about how they were infected. And they were not willing to do that.
They were being CEDA, the Swedish agencies. Yeah.
It wasn't CEDA. It was a parallel organization called SAREC, which was sort of the Swedish agency for research cooperation with low-income countries. And they were not willing to fund that situation. So we were sort of, they had planned that we should continue for a longer time to analyze all the data we had collected in Guinea-Bissau, but then the contract was stopped in the summer of '81, and I went back to the university and had to find other ways of getting back and actually study what had happened. So it took a long time to actually get all the data. It was first in '82 I actually could make all the interviews, and we started publishing the papers in '83. So sort of the academic side of it started from '83. But what had also happened in that process was that since we've had this very severe epidemic, we thought that we should actually provide measles vaccination to the community. This is the late 70s. There was an official vaccination program by WHO which started in '74 after the eradication of smallpox. The team which had started smallpox eradication, they were also sort of proposing to have a general vaccination program, and that started in '74. And there were recommendations for many of the vaccines, but a lot of the African countries did not use that program. So there were no real vaccination program in Guinea-Bissau at the time. There was only smallpox vaccination. If you had to travel abroad, you had to have a smallpox vaccination. So none of the children had been measles vaccinated when we had the first epidemic in '79. So we thought that when we re-examined the community after 1 year, that we should provide measles vaccination to the kids. So what that then happened was that we vaccinated all children between six years and 6 months. So that age group, we vaccinated all the children. And when, at the time, a lot of people thought that vaccination was not really important because it was the malnutrition which was important. And was important in the sense that people believed that if you were a malnourished child but was saved for one infection, you would just die from some other infections. A lot of famous people that time have sort of put their name on that very simple Darwinistic theory that is the weak ones who die. But that was the mental landscape at the time. And when it started to become clear for us, this was in 81, that it wasn't malnutrition. At that time, there were no facility for analyzing the data in Guinea-Bissau, so we had to go back to Sweden. So we sat for 1 year in Sweden, linked up to a mainframe computer, and try to get the statistics out of the data we had collected. And what occurred then, when it became increasingly clear that it was not malnutrition, then I started thinking, if that's true, then you can actually imagine that the vaccination would have an important effect in terms of preventing measles. And therefore...
So you are saying, just to get it clear, you're saying if it was believed that malnutrition killed the children, so if you vaccinated against measles, it wouldn't have any effect because the malnourished children would just catch the next infection coming around and die from that one.
Yeah, you might just change the course of death, not the fact that they would die.
But when you saw that malnutrition wasn't a major determinant for measles, then suddenly for measles mortality and seeing this high, like 1 out of every 4 child who got measles dying from measles, then really it looked like a good idea to give measles vaccine. That changed kind of the whole narrative about the measles vaccine in that sense that it might very well prevent very healthy children from dying also.
Yeah, but that was sort of, I think initially we provided measles vaccination just as a service to the community. We had been working there and measles was a big problem, therefore we provided measles vaccination. It was only a bit later we actually found out that there was no link at all. If something is really critical, it takes a long time to convince yourself that you are right, that you are on the right track. So we had the data, it didn't fit, the children did not look malnourished, but it took 2 years before we as a group decided that there's no link between malnutrition and measles mortality. And it was only at that time when that became clear, the center said, what does then happen when you provide measles vaccination in this population? And it happened that the team we had worked with, the Guineans we had worked with, they continued to collect data in Guinea-Bissau. So they had sent us sort of quarterly report with updates on what was happening in the population they have followed. So they sent lists with all the kids in the different communities that we were following. And since we had vaccinated in the major urban area, Bandim, they received a report from them or which children had died since we left. And I could then go back and I sat with all the papers from the vaccination campaign, the final vaccination campaign, and then saw the list of the children who had died subsequently in the following month. And I can still sort of vividly remember the feeling, this is unbelievable. Because every time there was a children who died, I went back and see what had happened during. Please remember, this is a time where everything was on papers and handwriting. It was not sort of a computer which you could go in and find the child. So you had to find the paper form where you had the information of the child. And every time the child has died, I went back and saw That child had not been present. It had been traveling at the time we had our campaign, so that child would not have been vaccinated. We had vaccinated 85% of the children, but in Bandim there was always be a lot of children who were traveling because they had to go back to the rural areas to make ceremonies, or they had to help their family with their harvest so that they could get rice for their own consumption. So there's always 15 to 20% who are away, and therefore there were 15 to 20% that we could not vaccinate, because we only vaccinated one day sort of in each district. And when I was sitting there with the papers, sort of child after child had died and none of them had been vaccinated, you get this very strange feeling, this is unbelievable. But you did it again, and it was repeated. And that was probably the first time where I really had the feeling, this is unbelievable, this is extraordinary, maybe this is very important. But we didn't call it non-specific effect. It was just sort of a feeling, how can measles have this enormous, measles vaccination have this enormous effect? And if you think about it, mostly you think measles mortality is the children who die in the first month after measles. They die in the acute phase of measles. So all the statistics on measles is sort of based on the children who die within the first month. So the first reaction to this observation was that...
And just to make it completely clear, your observation was that measles vaccine, those who got measles vaccine had a very low risk of dying compared with those who hadn't gotten measles vaccine.
Yeah.
It was more than... How much lower was the mortality?
I think it was a 7-fold difference in mortality. And you rarely find that level of differences in mortality. So, but how do you're always influenced by what you already knew and what the thinking you have had previously. So the first idea to this was that maybe the children, measles was not what we had thought measles was. So we thought that measles maybe induced immune suppression, and there was a long-term effect of the disease, and by vaccinating you prevented both the acute, but you also prevented the delayed effect of measles. So for a long period we worked on this idea that the reason we had this major effect on measles was that you prevented measles, the secondary or long-term effect of measles infection.
So measles vaccination reduced mortality 7-fold because it reduced both the acute death of acute measles and also long-term death following a measles infection.
That thinking was probably influenced by the fact that this is the time when HIV was discovered, that you had a virus which induced long-term negative effect on survival. So we, for several years in the late 80s, we tried to document whether there was delayed mortality after measles infection. And we did those studies both in Guinea-Bissau and in Senegal, where I had some collaboration. And surprisingly, it turned out that it was the opposite. Those children, and this may be a little bit complicated, but those children who survived the acute phase of measles the first month, they did not have higher mortality after measles infection. In fact, they tended to have lower mortality after measles infections. And we found that several times in Guinea-Bissau, and we found it in several data sets in Senegal. So I increasingly became convinced that there was actually measles could also have a beneficial effect. It can kill you, clearly. It's a very measles infection. It's very dangerous. It can kill you, but maybe it also trains the immune system. And that was sort of the whole perception we have, the medical perception is that all diseases are dangerous and we should get rid of them. So it's sort of it's a worldview where diseases are the enemy, and therefore the big thing is if you can eradicate a disease, then you get totally rid of it. This is the major victory in preventive medicine. And but here we've sort of, this suggests that you can actually have some benefit of the disease. So maybe it kills some children, but it saves some other children. So this was sort of gradually that became a new way of approaching it.
Vaccine curious.
So measles infection could actually be beneficial if you survive the first month. But how about measles vaccination then?
But the whole thing of, we had found that measles vaccination had this very strong effect, but it was still out. We tried to provide measles vaccination to all the kids in Bissau itself, the capital of Guinea-Bissau. So we had several programs, and we did that together with the Danish group IMCC, which is sort of a medical international organization for collaboration between medical students. So to maintain the data collection in Guinea-Bissau, I collaborated with IMCC. And so they had students there everywhere, and we tried to sort of get a program where we had vaccination in all the districts in Bissau, to do something, but also to do some studies in that process. And one of the things we did was to see if we could give measles earlier.
Measles vaccine.
Give measles vaccination earlier. The WHO policy is, at that time, was that you should vaccinate from 9 months of age. And really, the measles vaccination policy is based on the observation that you should vaccinate only when the mother's antibodies, the maternal antibodies, we're all born with our mother's antibodies. And so it's only when the mother's antibodies against measles has disappeared that you should vaccinate against measles. And that would normally be sort of between 12 months and 15 months. So in the Western world and the rich countries, we have vaccinated between 12 and 15 months in different countries. But in low-income countries where there are more children, you cannot wait that long because then too many children get measles. So 9 months has sort of been a compromise from WHO. But it's still based on the idea you should not vaccinate in the presence of maternal antibodies. So at that time, there was a new type of measles vaccine which apparently could immunize in the presence of maternal antibodies. So if you could give that vaccine earlier, I thought then we would have a much better, then we could save the children even earlier. So in collaboration with the researchers from Gambia, particular Professor Hilton Whittle, we started to do a study whether we could use this new measles vaccine already from 4 months of age. And that was also together with the students for IMCC. And we did 2 studies in the 84 to 88, where we used this vaccine and we randomized children to receive the vaccine and not receive the vaccine. So it was clearly the expectation that this would lead to lower mortality.
Just to get it right, you didn't randomize children not to get measles vaccine, did you?
No. When you do that kind of study, you cannot. It's only when you have a new vaccine, which is unknown, the effect is unknown, you can vaccinate to either get the vaccine or a placebo. In this case, when you have a policy already, you may be able to change the age, so you can give the vaccine earlier, and then the control group would receive the official policy to see whether that makes a difference, whether you got the measles vaccine at 4 months or whether you got the official at 9 months, which is the official age.
So you did a randomized trial of giving the new measles vaccine, which could be given earlier at 4 months, or just receiving the normal measles vaccine at 9 months.
Yeah. We actually did 2 studies over a period of 4 years. And we also did a study with our collaborators in Senegal. So there was a lot of enthusiasm also in WHO and other organizations at the time that this vaccine was really a vaccine which could help eradicate measles, because if you could vaccinate already at 4 or 5 months of age, you had a much better possibility of protecting everyone against measles. If you had to wait to 9 months or 12 months, there are too many children who would get measles. You could continue transmitting the infection. So we were very enthusiastic, and I think I at that time saw my own role, and a long-term role would be to take part in. I had seen the measles and had seen the mortality, so I really thought that it would be great if one could help eradicate measles infection. So that was my vision of my future at that time. It was clearly very influenced by the fact that I had seen all the children dying of measles in Bissau. When I came to Guinea-Bissau as 34 years of age at the time, I had not seen a dead person. And then suddenly in the first months there, I saw a lot of children who were dying. So that was a shock in the sense that, and I guess that became my mission, that I wanted to contribute to how can you reduce child mortality. The travel with this study, where I traveled back between Guinea-Bissau and the Gambia and Senegal to take part in these studies. And in the 8 of the 80s, we started to have the first results. And that really was not what we had expected. It had not reduced mortality. And I remember I was going up to Gambia to discuss with Hilton Whittle, with whom we have done this study. And I had been around interviewing all the families of the children who had taken part of the study, and I was sort of noting the children who had died, because this was still the time of paperwork. And so I was sitting in the car, one of my project drivers was taking me up there, and I was sitting in the car and writing down the children who had died. And instead of actually sort of just putting a line for every child, I put an F or an M to indicate whether it was a female or a male who had died. And the paper sort of grew, and I got far more and more children who had died. And what was stunning was that there were 3 times more girls who had died than boys. And that's not normal in any way. This is not like in South America, in Southeast Asia, where you will have sort of differential treatment of boys and girls. There are no differential treatment of boys and girls in Africa. Normally, girls have slightly lower mortality, like in the Western world. They had lower mortality than the boys. But suddenly I was sitting there with sort of 3 times more girls who had died. And that was a shock to all of us, because we had sort of done these trials, and the vaccine worked against measles. So one of the first paper we wrote was sort of, you can actually vaccinate already at 4 months of age and protect against measles. But when we had followed them up to 3 or 4 years of age, then you had higher mortality for those who had received the new vaccine.
So among those who were randomized to receive the measles vaccine at 4 months, there were many more girls that died, not boys.
3 times more than the boys. For the boys, it did not really matter whether you got the new vaccine or the old vaccine. But for the girls, it was a threefold higher risk of dying if you had received the new vaccine at 4 months rather than to receive the normal measles vaccine at 9 months of age.
You are listening to Vaccine Curious.
So, Peter, just to summarize, you had seen that children in Guinea-Bissau were not malnourished. They died nonetheless at a very high rate if they got measles infection. 1 out of 4 children died. The introduction of measles vaccine was associated with huge reductions in all-cause mortality that could not be explained just based on the prevention of measles infection. So you actually saw a 70%, a 7-fold reduction in the risk of dying among those who had received a measles vaccine in a campaign versus those who hadn't received the measles vaccine in the campaign. And at that time, measles vaccine was recommended at 9 months of age, but you thought that if measles vaccine could have such great effects, it might be even more beneficial to give it earlier on. So you were eager when WHO launched a new measles vaccine that could be given already at 4 months of age to actually test if that would lead to further reductions in child mortality. And this new high-titer measles vaccine, you then tested in randomized trials. So children were randomized, drawing a lot that determined whether they would receive the high-titer measles vaccine at 4 months or the standard titer measles vaccine at 9 months. And again, the expectation was you would see much lower mortality or even lower mortality among those children who had received the high-titer measles vaccine. But you just explained how when you were doing the tallies of all the children who had died, it became very clear that there was something wrong. There were more children dying in the group that had received the measles vaccine at 4 months of age, the high-titer measles vaccine at 4 months of age. And they were almost or very predominantly, it was females who died. So you were sitting there with observations both from Guinea-Bissau but also from collaborator sites in Senegal, I think, showing identical patterns of mortality and worryingly suggesting that this new high-titer measles vaccine that WHO had already rolled out in Africa was associated with increased female mortality.
The vaccine hadn't been rolled out. This happened just in 1989, and WHO, that was the year when WHO recommended this vaccine to be used in areas where there was a high risk of measles infection. And that was the same time that we found this strange observation with higher female mortality. And when I met that first statistics in the car, I and my collaborator, Professor Whittle in the Gambia, we wrote to WHO and said, we are concerned. Please, could they check whether any of the other studies which have used this vaccine experimentally had seen something similar. And initially, we did not receive an answer. It took some time and wrote again. And then they wrote back and said, thank you for your concern. We know that you have small numbers.
What did they mean by that?
That means that it had not been our initial hypothesis that it was an effect only for females. So if you took all children together, this was not really statistically significant. It was not less than 5%. It was less than 6%. But that was not acceptable because it was not accepted in that sort of the culture of testing medical theories. It has to be below 5%. But the fact that it was totally different pattern for boys and girls did not really count in that perception. To me, as an anthropologist, it was totally stunning that this was separately for boys and girls. That was the key. It wasn't key whether it was 5% or 6%. But
the statistical significance test, yeah.
They then wrote, we had written, and when WHO, they kind of said they would send it forward to another committee, and we never heard anything further. Then I went to Senegal, or not Senegal. I went to Harvard, where the guy who had done the study in Senegal, he was working at Harvard at that time. So I went there to analyze the data to see whether there was anything similar in the data from Senegal, and there was higher female mortality also in the data from Senegal. So we wrote again to WHO, and they did not answer. But I happened to be on another committee, so I was in Geneva in I think September, October 90. And then I went over to the vaccination program and said, when I came, I met with a guy who was responsible for measles. And when I came, he said, aren't you happy that they have just, UNICEF has just sort of recommended 30 million doses of this new vaccine. And I said, are you sure you know what you're doing?
Was he sarcastic or
No.
He didn't know about your research results?
He didn't connect the point.
Okay.
He was just sort of happy that they had got a lot of money for this new measles vaccine. And even though I have written to him several times about our observation, it didn't really link. And it took a whole afternoon in the head office of the vaccination program. And I managed to convince them that we need to have some people to evaluate this. And it was kind of the first time they had this kind of complaint. So they agreed to have a committee of so-called experts, even though no one had actually studied this kind of problem before. They found some people who were experts in measles vaccination. And this happened in the fall of 90, and then in January 91, we had the first committee meeting where we presented our data from both Bissau and from Senegal, and sort of kind of suggested there was a problem here. But the 10 experts, said that they did not understand. We had not planned the study. So it could be sort of coincidence. When the study had not been planned, this could not be right. And I tried to say, sorry, but you don't plan to kill children in studies. So you could not have planned a study to show that this vaccine killed girls. But nonetheless, they said it was not planned, and they did not have a biological explanation. There was not a mechanism it was biologically implausible.
So just to get it right, you presented data from 2 different countries where the introduction of high-titer measles vaccine in a randomized trial versus the standard measles vaccine, where the group that received the high-titer measles vaccine at 4 months had much higher mortality, and it was particularly for the females.
Yeah.
So what is the likelihood that this would be a chance finding? That you have 2 so extreme observations in 2 different settings?
These things are complicated, but in Bissau it was higher mortality. In Senegal it was only higher mortality for the girls. And the Senegal study was not really finished. So the attitude of those people was that the Senegal study did not count very much because it wasn't finished. Follow-up had not been finished. But you had this same differential effect that it was associated with higher female mortality. That was what counted for me to say that we have a problem here. So the conclusion was that there was no problem. And I guess we had suggested that we should have a watch out for this. Instead, they said recommended to go ahead with this vaccination.
So just continue rolling out the high-titer measles vaccine in spite of the...
Just when it started, when they had been approved in 89, and to produce the vaccine they needed, it took time. So it was only in 91 it started to be rolled out. And during 91, there were then more studies being done. Other people who had done studies, one of them had taken part in the WHO committee, which had rejected that there was a problem. He went back to Haiti to find out what had actually happened on Haiti. And the same thing had happened on Haiti. There were higher female mortality, which there should normally not be. And there was also, the Canadians had done a study in Sudan, and they also found higher female mortality. So those things which happened, or those analyses which happened in 91, they kind of led WHO to have a new meeting in 92. So in 92 there was a meeting in Atlanta, close to CDC, to try to handle. There was a new group of experts, and this time they concluded that it had been repeatable. They didn't really understand it, but it had been repeatable, and therefore they had to stop it. So they recommended that this vaccine should no longer be used. And they gave no real reason for how could this happen. But you can say it was during this meeting in Atlanta that I had to explain to all the data we had at that time from to my collaborators, and those collaborators were from Gambia and Senegal, and the Americans had funded the study in Senegal, so there were also people from CDC who was taking part in this discussion. So you could say in that kind of, it wasn't that moment that I had to explain what is different here. Everyone at that time sort of believed that vaccines have a specific effect against the disease that it's planned to protect against. And in terms of explaining that there's something we don't understand, I think that was the first time I kind of used the word that the vaccines must have non-specific effects. And the reason for saying that was that we had several observations which did not fit what people had normally assumed to be true. The first point was that measles vaccine reduced mortality much more than expected. Normal measles vaccine reduced mortality much more than expected. High-titer measles vaccine, on the other hand, increased mortality, and it only increased it for girls. That again did not really make sense. And I guess the third thing was also that we had seen that measles infection as such, though it can kill in the acute phase, afterwards it seems to have a beneficial effect on the survival of the kids, which kind of suggests that the disease trains the immune system. So it was a combination of those observations which really led to the idea that the vaccine has non-specific effects.
Vaccine curious.
What did people say in Atlanta when you presented this idea that vaccines have non-specific effects?
They were receptive because this was just for my collaborators. That was not for the big meeting. The big meeting was just about the data which have come from Sudan and Haiti to say that this vaccine has negative effect. But for the high-titer. But for my collaborators, they kind of shared some of the same experience, so it made sense to them that vaccine must actually have other effects than those we normally look at. So I guess the problem is that we have only looked at what we had planned with the vaccines. We hadn't considered the possibility that the intervention we make may have totally other effects than those we have planned. And that has been sort of the basis for now 30 years of work on what does the non-specific effects mean for vaccines. I should say that a lot of people have, not a lot, but several people have, in connection with the development of different vaccines, they have seen patterns which suggested that the vaccine had non-specific effect. Already when smallpox vaccination was introduced in 1798, there were people who would start, when the first smallpox vaccine were initiated, they said, it looks like this vaccine protects against other diseases. And when TB vaccine was introduced in the 1920s, there were also several people who, including the inventor of the vaccine, Calmette, who wrote that this vaccine seems to protect against other things. They didn't precisely use the concept non-specific effect, but that was what they thought about. And in the 60s, when the oral polio vaccine, the vaccine against polio was developed, there were Russian researchers who used this vaccine and got the impression that this vaccine did a lot of other things, that this vaccine was actually better to protect against influenza than the actual annual influenza vaccination. So they also talked about the strange effects of the vaccines. The issue is that most of these observations has not been accepted by the mainstream in medicine. So they stand as separate observation for smallpox and for Calmette vaccine and for polio, and has really not been pursued in terms of what's the implication of that.
So, Peter, you summarized your findings of non-specific effects of vaccines in I think you first used the term in a paper published in 1995. You had published the incredibly beneficial effects of the standard measles vaccine already in the 80s, but I think it was first in a BMJ paper in 1995, a hallmark paper where you raised the hypothesis and formulate the hypothesis that measles vaccine can have beneficial non-specific effects. But when we look back 100 years from now, would we then say there was incidence or the observation with smallpox vaccine, there was one with BCG vaccine in the 1920s, with all polio vaccine in the 1960s, and then there was Peter Aaby with measles vaccine in 1995. Will that be an island also, do you think, or have we reached a point where non-specific effects are here to stay?
I certainly hope so, since I have used my life on it. I hope it's here to stay, and for the benefit of humans, it certainly should stay. I guess the medical profession have provided sort of humanity with a very specific approach to disease prevention, because diseases are the key point of what physicians do. So everything is focused on specific diseases. I think which comes out of the story about the non-specific effect is really, maybe it's more important what the immune system does. So health is not the absence of all infections. Health is having a strong immune system. So apparently some of the vaccines can actually strengthen the immune system and provide sort of unheard of benefits in terms of child survival. So we haven't had the time to do that, but for all these live vaccines, whether measles, smallpox, BCG, the Calmette vaccine, and the oral polio vaccine, we have shown that they have very, very strong effect on child survival. So if we learn to understand what the immune system does and how you should interact with the immune system, you can reach very strong reductions in child mortality.
On that positive note, we will end. I hope to persuade you to come back to do another podcast at another time, because you have many different research agendas that we haven't even started to discuss this time. But for now, thank you very much, Peter Aaby, Professor in Global Health and Childhood Vaccines at University of Southern Denmark.
You've listened to Vaccine Curious with your host, Professor in Global Health from University of Southern Denmark, Christine Steppel-Ben. Thanks for listening.